Our last session today features Peter Harris. Um, he is a member of, our National Scientific Advisory Board and also at the Mayo Clinic. Um, and he's going to share Mayo's streamlined process for diagnosing ADTKD and referring patients to the International Registry at Wake Forest University. Peter?
Hi, how are you?
I am great. Thank you for joining us today.
Just trying to share these things. Oh, let me put it onto the show a minute. Is that okay now?
Yes, we can see you and hear you fine. Thanks.
Okay. So I think I'm going to reiterate quite a lot of things you've been hearing about the difficulty of diagnosing ADTKD without genetic testing. So the importance of genetic testing, importance of referring patients so that they are introduced into the registry, and at the end, I just do a little bit of comparison with autosomal dominant polycystic kidney disease. So right now, I'm at a meeting of the PKD Foundation, a grants review session. So this is a kind of working at a parallel foundation right now. So I thought I'd start with just a couple of patients, just to reiterate the points I've been trying to make. This is one with kidney failure at 60 years of age. You can see here a strong family history suggesting dominant inheritance. You can see some complications coming with CKD. There's a few other things here that maybe you wouldn't expect in ADTKD. Pancreatic cysts, a possibility of FSGS here, as well as tubular atrophy. And you can see the kidneys here, they have multiple cysts in, maybe more again than we'd expect normally in an ADTKD patient, but maybe this is because they're at end stage here. But you can see that the genetic testing identified a UMOD variant, and although this was initially called as a VUS by the testing company, we highlighted that this has been described before as a UMOD variant of significance, and so they upgraded to ADP to a lightly pathogenic change, and the listing of variants at Wake Forest is very useful as a reference for this. Here's a second patient here. We can see again the declining kidney function at 35 years of age. You can see a few cysts within the kidney, of a large cyst here, for instance. The family history here is a little unclear, although there was some suggestion that the grandfather may have kidney disease. You can see that the kidneys are quite small, so not really large like we see in ADPKD. You can see the initial genetic testing using a genetic testing panel came back with a variant in a glomerular disease gene, but this is recessive and probably not important here. Likewise, a ciliopathy gene came up with a truncating change here. But again, this is a recessive disease, so not likely important, although some ciliopathy genes, such as IFT140, have been associated with a PKD-like phenotype. So maybe they could be associated with the cysts we see in this patient. But we didn't think that these fully satisfied or explain the disease that we're seeing in the patient here. So we sent to Wake Forest the Broad for MUC1 specific testing, and that came out as positive for the canonical C insertion that is seen with this disease. So if we think about how we deal with patients at Mayo in our virtual genetic nephrology clinic, So these might be patients that have a family history of CKD. So we typically refer them for a genetic testing here. This can be Natera testing with a gene panel or variantics, which is again looking at kidney disease genes, but this time on a whole genome background. Both of these methods are good for identifying UMOD variants, but neither of them, as you've heard, are really good for finding MUC1 variants. So if they're negative from this testing, we refer for MUC1 testing to Wake Forest. Just a few things to think about here. Not all ADTKD patients are going to have a positive family history. Genetic results, you can come back as we saw in the second case there, can be quite confusing, suggesting other things that might be significant. And the in the presentation also can be rather confusing as well. As we've heard, it could be described as hypertensive related CKD or maybe diabetic CKD. And there may be other comorbidities, as we saw with that FSGS in one case. So I think genetic testing in a broad way for patients with a decline in kidney function and no clear example, and especially if there's a family history, is warranted. So what do we suggest when an ADPKD patient is diagnosed? So the local nephrologist is still going to care for that patient. And as we saw before, or Herb mentioned, cascade testing can be very helpful in a dominant disease like this to try and identify other affected members. And as we heard also, this is the insurances will usually cover this type of testing, as it will the primary testing. Then we inform the patient and the family about Dr. Blyer and the Wake Forest team. We also inform them about the Rare Kidney Disease Foundation. We have some nice leaflets that they kindly sent to us to help with that. We've stressed the importance for clinical trials of the value of being added to the International ADTKD registry. And we can also supply, with the patient's permission, we can also give contact information to the Wake Forest group. So I think that the importance of genetic testing here, just want to emphasize ADTKD is obviously difficult to diagnose just on the clinical grounds. So genetic testing is definitely needed. In some cases, the specific MUC1 testing. The disease is fairly rare, although probably greatly underdiagnosed. So large populations that have been defined genetically are going to be important for doing clinical trials. We can, once we've identified one member, we can identify other family members, and this allows them to be known and so candidates for a future clinical trial. And likewise, the renal clinic that is seeing these patients may also be a site which will be able to host a clinical trial in the future. Finally, I just wanted to just do some sort of comparisons with ADPKD. So this is a much more common disease, around 1 in 1,000 individuals affected. In this case, the major genes were identified more than 30 years ago, although as you heard earlier, there are some minor genes still being identified. The first, and in fact, only approved treatment, tolvaptan, was approved around 8 years ago. So you can see that this was a very long period of time. I think the hope would be that it certainly would not be as long as this for ADTKD. And I think there's reasons for hope there in the development of the technology for ASO treatments, gene editing, also our better understanding of folding and trafficking drugs that have been pioneered for CF. Also, I think the pathogenesis of ADTKD is better understood than ADPKD. So there's now many therapies that are being tested either clinically or preclinically in ADPKD. Is probably 20 companies that are involved in these studies right now. I think one thing that's been important for designing clinical studies and clinical trials is to have large populations that have been collected and characterized. In this case, imaging is very important, looking at the size of the kidneys, the genetics, as we've discussed, and also longitudinal outcome data. And these have been key to designing clinical trials in ADTKD. And so I think this is another reason for referring patients to the International ADTKD registry so that we can get a better idea about the natural history of the disease, which is going to help the design of clinical trials. I think that's all I have to say, but thank you.
Thank you very much, Peter. And I'm mindful of the time here. And so, can I request, Peter, that if we get questions from folks, that we can send them to you and you can answer them and we'll post them after the summit.
Sounds great.
All
Thank you.
right. Thanks so much.
Okay, bye.
Um,